Well, good morning, everyone. It is about 8:05, so we will go ahead and get started. I'm sure some other participants will be joining us over time. But welcome. Mark Pascone asked me to kick this off this morning. So I am Lee Revere, and I am a faculty member at the School of Public Health. And also on the ACHE chapter board, I serve as your secretary and assistant treasurer. So I'm happy to be here this morning. We are attempting to record this WebEx session so that we can share it with other individuals that weren't able to make it today. So I would like to welcome you to the seminar, which we are putting on jointly between the ACHE Southeast Texas chapter and the University of Texas School of Public Health. I'm going to be your moderator for the seminar. So please send me any questions that you might have for our keynote speaker via the chat. And at the end of today's lecture, I'll go through the chat and read out the questions for Dr. Troisi. Also, if you would do me the favor of putting yourself on mute so that we don't have any background noise that can be distracting. I also have the ability to mute, so I will do that as well if I'm able to. And we're going to address all of your questions, hopefully, and this will be a fantastic learning experience for everyone about the COVID-19 pandemic. So we'd like to thank our chapter sponsors for their support for this webinar and our other educational events. Our charter members include Texas Children's Hospital, Houston Methodist, CHI St. Luke's Health, Memorial Hermann Health System, MD Anderson Cancer Center, and HCA Houston Healthcare. Our Diamond Plus sponsors include Metastar and the Intercontinental Houston Medical Center. Our Platinum partners are Bain, Clear Balance, Kirksey Architecture, Pearl Meyer, Page, J. Tyler, Thayer O'Neill, and Kindred Healthcare. We also have the Lineback Group, the University of Houston Clear Lake Center for Executive Education, Texas A&M University, and the UT School of Public Health. So thank you all for sponsoring the ACHE Southeast Texas chapter. Without your support, we would not be able to put on these wonderful events for our members. So now I would like to turn the focus and welcome our expert speaker, Dr. Kathy Troisi. She is a faculty member and an associate professor in the divisions of management, policy, and community health, as well as epidemiology at the University of Texas School of Public Health. She will be our keynote speaker today, presenting COVID-19, the perfect pandemic. So Kathy is also the coordinator for the Leadership Theory and Practice Certificate at the University of Texas School of Public Health, and has previously served as the assistant director at the Houston Health Department. Kathy teaches courses in public health and leadership with research interests in infectious disease epidemiology. She holds a BA in chemistry from the University of Rochester, an MS in biochemistry from Michigan State University, and a PhD in epidemiologic sciences from the University of Michigan. Kathy has completed the National Public Health Leadership Training in February of 2011 and received the UT School of Public Health Community Service Award in 2013 as well as 2019. She's also earned the Excellence in Teaching Award in 2017. Dr. Troisi has received the American Public Health Association Advocacy Award in 2015 and was elected to the association's executive board in 2017. She is active with the Texas affiliate as well, receiving the Texas Public Health Association Award for Outstanding Service in 2010. Kathy is the recipient of the 2018 Association of School and Programs in Public Health Academic Public Health Practice Excellence Award. She is a board member of the International Network of Epidemiology and Policy, as well as many local and state public health advisory boards. Kathy has over 16 op-eds published in Texas newspapers and has given over 150 media interviews on public health issues. So I'd like to just say welcome to Kathy and thank her very much for taking her time this morning to share her expertise with our group. So at this point, I'll turn it over to her and I'll mute myself.
All right, thank you, Lee. I'm delighted to be here today to talk to you about our current pandemic. I've given this talk a number of times, and the first one was on February 5th of this year. and to see how the talk has changed through those 2 months, 3 months, is just shows how much we're learning. And if you are watching this taped, I want you to note the date, maybe May 14th, because we're learning more every day and things are changing rapidly. I do a call-in show on KUHF where listeners can call in with questions, and I swear most of my answers are, well, we don't really know yet. You know, it's still early in this pandemic, but I'm going to tell you what we do know and what we'd like to know and what we think, what's happening, what we think might happen. So let's see there. All right, so I'm not going to spend a lot of time on the virus and the clinical symptoms because I assume you're all pretty familiar with that. But we do know that this is a respiratory virus. It's spread through droplets, which are larger little blobs of saliva that go through the air. They typically only go about 6 feet, which is why we use that for physical distancing. Although there have been reports of droplets going up to 20 feet, and apparently some of us are better spreaders than others. Some of us spit more, I guess. It also happens through personal contact, environmental surfaces, although a study I just saw showed that only about 6% of transmission occurs through these fomites. Now, that's a hard thing to study, but most public health experts think that transmission is mostly through the respiratory route, not through environmental. And then the big question is there aerosol transmission. Aerosol consists of much smaller particles, and they can linger in the air for hours. Measles is spread this way, and that's one of the reasons why measles is so contagious. So there's been aerosol can definitely happen when you're doing certain medical procedures. We're just not sure what role it plays outside of the hospital. The incubation period varies from right away to 2 weeks. The mean seems to be around 5 days. About a fifth of the cases are severe, meaning hospitalization. And although because of the lack of sufficient testing, we're not quite sure what that number will turn out to be in the end. We also know that a significant portion, although whether it's a quarter, whether it's half of infections are asymptomatic, occur. And this is very important when it comes to transmission, because if you're sick, hopefully you're staying home. If you don't have any symptoms, then you may go about your business once restrictions are lifted, but also even right now, you may be less careful about what you're doing. We think about 2% of those infected die. I have heard up to 6%. Again, with the lack of testing, we only know the case fatality rate, not the infection fatality rate. And so the range is between 0.5% to 3.5%. To put that into context, that's about what we think it was during the 1918 pandemic. We know that there are certain people who are at a higher risk of dying, elderly, although honestly, I wish we would stop using that term for people over 65. We need a different one, seniors maybe. Those who are morbidly obese, if you have a heart disease, diabetes, other lung conditions, autoimmune diseases, there appear to be a number of risk factors. We know that people can shed the virus early in the infection before you even have symptoms, if you are going to develop symptoms. And again, this has ramifications for the transmission of disease. And as I said, those who are never going to have symptoms can also shed virus. This virus attaches through the ACE2 receptor on cells, and there are many organs that have this receptor. So what we're finding is that it's not just a respiratory disease, that there can be heart damage, brain, kidneys, as well as lung that are infected. And this we may find out, we're beginning to find out, that there can be long-term sequelae. So if you have a bad infection and you don't die, that's good, but recovery may take a long time. And as I said, there may be long-term consequences. So there's a lot that we don't know. We don't know when a person is most infectious. We know that you can transmit the infection before you have symptoms, or if you're never going to have symptoms, but we'd like to know what the peak is. We don't know what % of the population has been infected. We're starting to do antibody studies, but it's hard to get a random sample, and the tests that are out there are not that great. As I mentioned, we don't know the case fatality rate or the infection fatality rate. We have some guesses, but we don't know for sure. One of the big questions right now is immune protection after infection. The questions are, does everybody who's infected develop antibodies, or do you have to have a more severe infection to develop antibodies? We don't know how long immune protection lasts, and how long it lasts depend on the severity of infection. We do know with other coronaviruses that immunity is short-lived, years, not months, but we're just not sure with this. We don't know what the true R naught is. This is a measure of infectivity. We have different estimates. It seems to be around 2 to 3, meaning that each person infected on average infects 2 to 3 other people. However, there are super spreaders who, for whatever reason, viral load or not, maybe they spit more, that can infect a large number of people. As I mentioned, we really want to know about aerosol transmission because that has implications for preventive measures. One of the questions that has been asked a lot is whether high-dose transmission is linked to severity. Certainly, high-dose transmission is linked to infection. That is, if you come in contact with somebody who has a higher viral load, is expelling more virus, you are more likely to become infected. But what we don't know is if you get a higher dose of virus at the start, does that link to the severity of your clinical disease? We'd sure like to know how long the virus can remain in the environment. There are preliminary reports under lab conditions. We don't know out in the real world. It's an envelope virus, which means that it is more labile in the environment, but as these reports show, at least under laboratory conditions, it can last for a while. Another thing we'd really like to know, what's going to happen when warmer weather occurs. It's looking like it's not going to disappear. Some respiratory viruses do, some don't. If you look at other coronaviruses, about half of them do, half of them don't. But looking at other parts of the world where it's already warm and humid, we have not seen a decrease in cases. And then I'll talk about the possibility of a second or third or fourth wave in the fall and subsequent years. And a big question relating to what we do about reopening schools is, are children drivers of the infection? We know that with influenza they are. We're not sure with this virus. Children do get infected. Luckily, usually they are either asymptomatic or mild symptoms. We are learning about some children, usually with underlying medical conditions, who do not do as well. But the question is, are they bringing, if they were in school, would they be bringing the infection home to parents and grandparents? So why is this virus causing the perfect, and I use that not in the good sense, but in the couldn't be a better virus to cause a pandemic sense. So there are a number of things about the virus and then about society. So this is a new virus. We think it came from bats and drew probably a pangolin, I should have put a picture of one up there. They're so ugly, they're cute. And they are used in Chinese medicine for something, and that's why they were in the wet market in Wuhan. So this is a new coronavirus. there are 7 others that infect humans, and lots that infect animals. So what that means is that nobody has immunity to it. There's no cross-reactivity with other coronaviruses that we probably all have experienced. There are 4 coronaviruses that cause the common cold, and we think that about 1/3 of all colds are caused by one of these coronaviruses, but you don't get any protection if you've had a cold with one of these coronaviruses. It is a highly infectious virus. As I said, the estimates right now for R0 are 2 to 3. I have a feeling we're going to find it's actually higher than that. Although I did just read a study published from China looking at household contacts of people who had tested positive for this SARS-CoV-2. And what they found was that household transmission only took place in 17% of the cases. And this was a number of cases. It wasn't a small number. And if the family member who was COVID-19 positive quarantined themselves within the household, there was 0 transmission. So that's good news. It has a short incubation period. As I mentioned, it can be between 1 and 14 days, average of 5, which means that it can spread pretty rapidly, unlike other diseases like smallpox, which we have successfully eradicated. It has a low death rate. Now, that may sound like a good thing, and certainly it is, but what that means is that there are lots of people who are going to be susceptible, and from a societal standpoint, we don't fear it as much as a virus that kills half of the people. It is infectious before symptoms occur. That means people don't know they're infected, it can be infecting other people. And this certain percent, maybe even as high as half of people, don't ever get symptoms, but still can transmit the virus to others. We don't have a vaccine yet, and we don't have any good antivirals or other therapeutics, although certainly people are working on that. And then also the fact that the virus uses the ACE2 cell receptor to enter organs, to enter cells, and this receptor is on a lot of organs. So there's a lot of ways clinically that you can be infected. There are also some societal features that make this virus the perfect pandemic. One is global travel. We, back in the days of the Black Death, people didn't travel so much. Now you can be around the world in less than a day. And indeed, if you look at flights out of Wuhan before the airports were shut down, before we knew about this infection, there were about 3,500 people every day leaving the country from Wuhan. So you can see that the possibility for spread around the world quickly is very high. We also now have, wasn't around in 1918, social media. And this is spreading both information and misinformation about the virus. And if people are not getting correct information, they may not adhere to prevention standards that would help stop the pandemic. We were not prepared for this pandemic or any pandemic. When I was in graduate school 40 years ago, we talked about when the next pandemic would happen. We had SARS in 2003. Because of different characteristics of the virus, we were able to stop that after a year, 18 months. And there were 8,000 people infected, 800 died. So certainly nothing like this. We then in 2009 had H1N1. I was working at the health department then. We were very, very concerned that this was going to be the next pandemic because we all thought it was going to be flu. But luckily this H1N1 that circulated did not have a high mortality rate. It infected a lot of people, and there were unfortunately children who died, but it wasn't as bad as we had feared. We knew this was coming, and yet we were not prepared for it. I teach a course on Introduction to Public Health, and I have my students recite every day, public health is political. We don't like to think that it is. We want to think that it's science-based, but as we are seeing, and apparently came to as a shock to Judge Hidalgo, public health is political. And so it's an interesting phenomena now where wearing a mask or not is a political statement, not a scientific, reasonable thing to do. And then the lack of a national strategy. Public health is a state's issue. That's how it's written in the Constitution, so that it's state and local health departments that have the authority. CDC can only come into a state if they are invited. Now, usually they would be, but because of these, because it is a state's rights issue, we see that different things are happening in different states. You know, that would be great if we didn't travel, but people do move from state to state and jurisdiction to jurisdiction, so that the possibility of spread to a place that has limited the number of new infections is possible. So one of the, as I mentioned, we don't have a vaccine, we don't have therapeutics yet, so we are relying on non-pharmaceutical interventions. And one of these is community mitigation. We know that this works from the 1918 pandemic. Sorry, I swear it's allergies and I'm not sick. If we look at two cities that had different measures in place, Philadelphia and St. Louis, Philadelphia delayed implementation of these interventions. You can see that picture. They allowed a big parade in September when the flu was coming back with a vengeance, and that solid line in the graph shows the number of cases. St. Louis, rather, on the other hand, implemented measures early on, and you can see that they were able to flatten the curve and decrease the number of infections and deaths. Now, we also have looked at this from the current pandemic. This was, should have the reference there, sorry. This was just published, showing non-pharmaceutical interventions by in different countries and the relative peak death rate. Now, and you can see that there's a correlation there, that the countries that had higher guidelines in place or laws in place about things that could be open, about leaving your house, all those community mitigation techniques had a lower relative peak death rate than countries that had looser guidelines. Now, there is another graph I'm not showing, another table that is that shows the absolute peak death rate, and there is not a correlation there. What the authors assume or propose is that this is because even in those countries that did have stricter NPIs, they weren't in place for a long enough time. And the authors, the average was only 36 days. And the authors speculate that we may need to have at least 12 weeks of these mitigation effects or guidelines in place. So this is from May 6th, sorry, but it goes through April 30th, showing that people are or were staying home. And you can see for Texas at the peak, maybe 94% of people were staying home based on cell phone data. And that had already started to decrease even before our guidelines were lifted, but still 87%, that's pretty good. This is from the New York Times yesterday, 2 days ago, showing the changes in people staying home in states that had reopened, Texas being one of them, and you can see that we already saw an 8% decrease in the number of people staying home. But that was then, and I'm sure these pictures are familiar to you. We're seeing a lot of resistance to these stay-at-home orders. I will talk about that a little bit, but here's the public health is political aspect. However, my mother, a lot of mothers have the saying, just because you can do something doesn't mean you should do something. And it's been pretty remarkable how many people think that it is too early to lift these restrictions. If you look between 75, 80, 86% of people say that the U.S. should try to spread the stop the spread of coronavirus, or at least slow it down, by keeping businesses closed, even if it hurts the economy. Whereas 25% say we should open up businesses, even if there are going to be more infections. If you look in Texas, 60% say that we're moving too quickly. So again, it's going to be interesting to see as businesses open how much business they are getting. Now, I think restaurants, even though right now they can only have 25% of their occupancy, I think that they are seeing business. I got takeout last night from a restaurant that I thought only did takeout, because right now I'm only patronizing restaurants that are not having dine-in. But I should have called, because they were open. I had to go in. They weren't doing curbside anymore. And nobody, except for the workers, were wearing masks in the restaurant. Now, I understand it's hard to wear a mask and eat, but there were other people ordering or picking up orders, and nobody was wearing a mask. You can see 85% oppose reopening schools. Almost everybody opposes resuming big sporting events. Local health officials and healthcare workers have a very high trust rate, unlike politicians in general. 93% trying to maintain that 6-foot distance. Now, I will say these polls are subject to the socially acceptable answer. So you may say that you're trying to do that when in reality you're not. And 80%, 4 out of 5 people say Americans should continue to social distance as long as needed. So this is what's happening in Texas and Houston. We have done, at least in Houston, a good job of flattening the curve. Our medical facilities, our hospitals are not at capacity. We are not seeing, the field hospital was disbanded. But we are not seeing a decrease. And this is from the 337 in Houston is from 2 days ago. Yesterday, there were 297 cases reported. Of course, there's always the caveat that without enough testing, we really don't know what's happening in the community. Testing is key to everything. If you look at the new coronavirus cases in Texas, although there are some peaks and valleys, it looks like it's still on an upward track. And indeed, yesterday, there were 1,571 cases. So we are still seeing the cases go up in Texas. There are very few things that I say definitely, but I will make a definite prediction here that as we open up, we are going to see more cases. So what's going to happen? My crystal ball isn't working so great today. And it's easy to predict. It's harder to be right about what has happened. Now, we know that the wave has not crested everywhere, and we're continuing to see hotspots. Dallas right now is seeing a big increase in cases. New York is past, Seattle is past, but there are a lot of the country still primed to have to become hotspots. We don't know what's going to happen in the summer and fall. what happens is really going to depend a lot on how long these physical distancing and other community mitigation guidelines last. And as we saw, they're already being loosened in parts of the country. And WHO just this morning made the prediction that this virus is just going to become endemic, like other respiratory viruses. The hope, of course, is that we will have a vaccine to protect people or herd immunity through the fact that just so many people have been infected. What's going to happen is going to depend on what we do as a society, and individual behavior, but also characteristics of the virus. This is an RNA virus. It could mutate for better or worse. So far, we haven't seen big changes in the RNA. You may have heard about a report that came out showing that there's 2 strains of the virus circulating and that one is more infectious than another. There's been a lot of pushback against that. It had not been peer reviewed yet, and they make a lot of assumptions. I mean, there are 2 strains. That's, genetic sequencing, but they made a lot of assumptions about whether one strain was more infectious than the other. So there are a lot of models out there. This is a graph from a paper where they take these 6 different models and combine them. So the reason the models vary so much is because they make different assumptions and about both the properties of the virus and such as how infectious it is and the rate that it's spreading, how many people die once they're infected, they're out of the pool, and they use different types of math. But probably most importantly is they make different assumptions about how long physical distancing is going to last. So if you look at the curve, I don't know if you can see my mouse or not, but the bottom ones, the lower estimates, they are assuming that these guidelines, these non-pharmaceutical intervention guidelines or laws, depending on where you are, will last till the end of June, where the highest one with the highest number of predicted deaths in Texas assume that it will last till the end of May even. So it's not even reflecting reality. Big question about, are we going to have a second wave? On the left-hand side, you see what happened in 1918. We had a small peak in the spring, big peak in the fall, a medium-sized peak in the spring of 1919, and then the virus disappeared. We did not have a vaccine. We probably had not reached herd immunity. Estimates are about 1/3 of the world was infected. We're not really sure what happens to the virus. There's a lot we still don't know about influenza virus. On the right-hand side, you can see some projections about what could happen with this coronavirus. The first one shows an initial wave of cases and then peaks and valleys that diminish over a year or 2 or 3. Scenario 2 assumes that this current peak will be followed by a big peak in the fall and maybe a winter peak and then subsequent waves. And then scenario number 3 shows an intense spring peak that we're in right now with a slow burn. So those are some of the projections about what could happen. This shows what we need to be doing, looking at in terms of community mitigation. It may be if we have these peaks that are, we have peaks and valleys, that when we reach a certain number of cases, we institute guidelines again. Now, politically, that's going to be very hard, but when we're in the valleys, it may give us a opportunity to relax some of the guidelines and give us a break. And then this bottom part just shows where we are towards reaching herd immunity. And it's going to take a while until we have a vaccine. So opening up, and we probably need a better term than that, because we are not opening up entirely. We are gradually lifting those restrictions. We need to be thinking about what we're going to do. We are thinking about how we're going to relax those restrictions, but we need to have something in place about what we're going to do if the number of cases reach an unacceptable level. Both the president's guidelines and Governor Abbott's guidelines indicated 4 things that needed to be in place before we started to relax these guidelines. The first is testing, that most cases are detected, that we're on the downside of the curve, that we have 14 days of decrease in cases, that the medical system has capacity to handle all the cases, that the numbers are small enough that we can trace them all, and that we have enough contact tracers. And then, as I mentioned, we need to have these procedures identified. A major caveat here is that, we do travel. So if Houston were able to get the cases down small enough that we could contact trace all of them, that doesn't mean that somebody from Dallas won't come visit and potentially bring the infection. Now, if you look at these 4 guidelines that should be in place, we have only met one of them, and that is the medical system is doing well, that we are not at capacity. So it's always a difficult trilemma that we are trying to balance saving lives with the economy, and then privacy. We'll get into a little bit of that with the apps. And so there are difficult decisions that need to be made. We do know in countries that seem to have adequately squashed infections that there were some common traits. Their early recognition of the virus, they tested. They had early and very strict quarantine and physical distancing guidelines. So let me talk about contact tracing just for a bit, because that has been in the news. This is a standard technique of public health. We use it for STIs, Ebola, measles outbreaks, other things. And the basic characteristics are you identify cases, you then identify their contacts, which can be a lot. For respiratory virus, we have a lot more contacts, hopefully, I guess, than if it's sexually transmitted disease. The number of partners is going to be less in most cases. And then you notify contacts they may have been exposed in self-quarantine. So, but it's a very time-intensive technique to use if you're using humans to do this, which is what we have traditionally used in public health. There needs to be cultural sensitivity when you're reaching out. Even though you're not asking about sexual partners, you still may be asking about some sensitive topics. We have the example of the researcher in London who broke his self-isolation by having his mistress come visit. And you may be reluctant to release that information to a government agency, which public health agencies are. There in certain communities, there's distrust of government agencies in the medical community for probably good reason. This is going to be made harder by the fact that it's going to be done through the phone, not person to person. The contact tracers are going to miss clues that you would get, verbal clues and physical clues you may get if you were interviewing somebody in person. We also are going to need a whole lot of them. The estimates are 100,000 contact tracers needed if the number of cases dropped significantly, but we aren't there yet. It's estimated that it would take 5 tracers 3 days to find 50 contacts. So you can see that one of the guidelines that should be in place before we open up is that the number of cases is small enough that these contact tracers can do that. Now we also have technology. These are where your cell phone sends a Bluetooth bing to other phones in the area. There's some problems with this as well. You'd have to have 60 to 80% of people have the app to make it worthwhile, to make it work. There are big privacy concerns about this, as you might imagine. The guidelines from the developers are this needs to be voluntary. So it's not like the government will be able to tell everybody you need to put this on your phone. And indeed, not everybody has smartphones. It uses Bluetooth technology, which goes through walls. So you could be in your apartment, the person in the apartment below you has a case of SARS-CoV-2, and your phones would ping because it goes through the walls, even though you really aren't at risk. And along with that, there's issues of how long you are in contact. We think you probably have to be in contact 10 or 15 minutes with a case to be infected, and how close you are. Again, we use that 6-foot distance. So if I were at the grocery store, and it can't tell if you're masked or not. If I were at the grocery store and someone at the grocery store turns up positive, but I am never close, that person is always in another part of the store, I would be, would I be dinged as being in contact? So to do this contact tracing, though, we have to be able to test the contacts. And again, testing is key. If half of infections are asymptomatic, that's going to be a big problem because you're only going to be detecting half of the cases. We still are learning a lot about the infection, about how transmission occurs. As I said, the number of cases right now is really too high to be able to do this effectively. And then health departments have not been funded well ever, particularly since the economic downturn in 2008. We've lost a lot of workers in public health. And so the staffing just isn't there. Now, you've probably seen that the School of Public Health, along with other University of Houston, other places, are training contact tracers to do this work to help out health departments. But long term, it's going to be an issue. I'll talk quickly about temperature checks. They've been suggested, you use infrared technology to detect someone's temperature as they enter a building for work or school. But one study has shown that only, at least at admission to the hospital, only about 30% of known cases were febrile. And then you've got your quarter to half of people who never show symptoms. So you're going to miss a number of people. The infrared gauges aren't that accurate. And there's a lot of reasons why you can have an elevated skin temperature. I think just being in Houston outside in the summer is probably enough. Privacy issues, this is medical information. And we have found that during SARS, although airport temp checks were put in place in many airports, they did not identify a single case. And we have not caught any cases of this virus through our airport screenings either, although people aren't traveling. And then there's always the possibility that people can take a leave or Advil or whatever to reduce their temperature. We're working on new antivirals and other therapeutics. We're working on new assays. We'd like them to be faster. We'd like them to be point of care. We'd like to have reliable antibody tests. I can go into some of the problems with these tests during question and answer if you'd like. Right now, the antibody tests are not that great. An antigen test was just FDA approved. It's only about 80% sensitive, but it is quicker. And then it would be good if we had at-home testing. We're also working on a vaccine. Vaccines typically take 20 years to develop. The fastest a vaccine has ever been developed is 4 years. That was mumps in the 1950s. Obviously, we have better lab techniques than to develop vaccines, but we want it to be effective. And this is going to be an issue right now because we don't know which antibody is neutralizing. You make many antibodies in response to a viral infection. We don't know which are going to be protective. We don't know how long the protection is going to last because we don't know how long it lasts with a natural infection. Obviously, we want it to be safe, and that means you have to undergo a lot of testing. There has been talk about challenge experiments because in order to show that a vaccine is effective, it needs to prevent infection, so someone has to be exposed. And if the number of cases goes down, then there may not be that opportunity, but you could challenge someone with the virus. There are a lot of ethical issues there. Once we get a vaccine, we have to scale up production, and we aren't really ready to do that. And that's hard to get ready for because we don't know what kind of vaccine it's going to be. The price is going to be an issue. Will everybody have access to it? And then acceptability. 1/3 of people, maybe it's 30%, right now say they wouldn't take it. You know, the anti-vaxxers are really gearing up now with this. I'm going to skip this slide. You'll have it just if you're interested in some of the things we're looking at for vaccine production. I would like to point out, however, though, that the assumption is the first vaccines will only be approved for 18 years and older. And if children are major drivers of the infection, that will cause some problems. So this isn't just a pandemic. We have a lot of economic consequences. It's an infodemic. Social media is spewing a lot of conspiracy theories. There are scams out there. A friend of mine told me that someone came to her door telling her that COVID was spread by mosquitoes and he would spray her yard for mosquitoes. She's a nurse and she knew to tell him to get lost. But a lot of people don't know that. Risk communication has not been that great from our leaders. We're not getting consistent information. And then just the lack of understanding of science in general and how science advances, that what scientists think is true today, we may have more data in a month and say we were wrong. This pandemic has thrown a highlight on inequities in our society. Our essential workers, who are, of course, healthcare workers and first responders, but also in grocery stores and bus drivers are not well paid, do not have paid sick leave, and are putting themselves at risk without proper PPE. The virus has, and death rates are higher among our communities of color, and then there are our vulnerable populations, which we have a moral duty to protect, and but are very hard to do that because of how crowded they are. So we need to start planning together. We need to have a community approach to this. It's not every man or woman for themselves. We need a national strategy. We need to be talking about medication shortages. And I'm not talking just about COVID ones, but for example, albuterol, there's concern about shortages because for people who have asthma, because it's being used in therapeutic methods for people who have COVID. We need to be talking about end of life and rationing treatment if that does become necessary. The vaccine, who gets it, who has to pay for it. There won't be unlimited supply at first. Who do we vaccinate first? And then immunity passports, this idea that if you test positive, you sort of have free reign because you are supposedly not immune. And I can talk about that more, about why that's a bad idea. We need to be talking about what has to be in place for schools to open, voting, a big issue in the fall. We need to think about whether our current healthcare models serve us well. And we need to be thinking about how society is going to look after this. And it's an opportunity for social justice and to promote public health. So how do pandemics end? One of two ways: either a medical end where incidence and disease plummet, either because the virus goes away or we have a vaccine. For example, smallpox, that was how it ended. The other way is through a social mechanism where fear of the disease wanes and people just stop adhering to the guidelines, and eventually there is herd immunity at a cost. We need to be thinking about what the lasting effects of this are going to be, particularly on our children. As I mentioned, this is an opportunity to address some of those inequities in society that have been maybe not revealed but highlighted. Hopefully public health funding will be increased, and we need to start preparing for the next pandemic because it will happen. It may not be up to 400 years, but it will happen. And then I just wanted to show these political cartoons about the conspiracy theories on the left, and about whether we're opening up society too soon in terms of preventing deaths. So that is it. And I'm happy to talk about any of these things I sort of touched on in more detail if you're interested.
Wonderful. Thank you, Kathy. That's very informative. And I think everybody learned a little bit from this, if not a lot. I do have a few questions in the chat. And so those of you that also have other questions, please feel free to send. And I'll start with a few here. So one question was, can you comment on the issue of false negatives with the antibody test? When such emphasis has been placed on these as a mechanism for us to return to normal, if you will.
Yeah, I certainly can. I've actually done a lot of research on that. It's actually less a problem of false negatives than false positives. If somebody tests negative and does not think they're immune, even if they are, they hopefully will keep taking precautions, so no harm done. It's the false positives where somebody thinks that they are positive, and the sensitivity of these tests is not great. So if they test positive, they may think they're immune. They're not. They stop taking protections and could get the infection and spread it. The FDA allowed tests to be put on the market without going through even emergency use authorization, although that has now changed. There were 140, 170, I forget, tests. A lot of tests out there hadn't been shown to work at all. That has, so now the FDA is requiring an EUA, but the sensitivity and specificity of these tests still are not great, and which is one reason why I think immunity passports at this time are a bad idea.
Good point. Do you know anything about the current state of how, even if you test that you have the antibody, how good is that? I mean, how long do you have it? Is it useful life of that?
Yeah, we don't know. And it's going to require some long-term population studies. We're only, what, 3, 4, 5 months. The virus may have been circulating since November, but the first cases were only detected, end of December. So we really need more time. It's a new virus. We need more time to follow up and see how long antibodies last.
Okay. Related to that, there's now been an increase in testing just of the general population, I guess, if you want to get tested. So how many individuals or what percent of people need to be tested or tested for the antibody, whichever direction, to really understand the prevalence of this virus in the community? Is there a kind of a general rule of thumb? And then I assume that would inform the models better.
So let me talk about antigen or virus testing, whether it's antigen or PCR, which detects the genetic material. It's, all that tells you is that today you're not infected. Now, if you're looking for population studies, if we could do a random sample, I'm working with some people at Baylor on this. It's really a hard problem. To determine a random sample that you can get consent from, because it is a research study, and some people don't like to have blood drawn if you're doing antibodies, or they just don't want to participate. They're not available because they're working, et cetera, et cetera. So certainly for research studies, I don't know what percent we'd have. I'd have to do the power studies on it. But if you've read about the antibody studies that have been done, there's been a lot of criticism. It's not just the tests that aren't good, the sampling hasn't been good. Facebook users are not a random sample. Grocery store patrons are not a random sample, which was done in New York. sorry, I'm mixing up. I'm going back and forth between antibody and antigen. The other thing is, I don't know of any infectious disease where we know what the prevalence of antibodies is in the community. We just don't usually look at it that way. When we look at herd immunity, for example, measles, we're basing it on immunization records. We're not basing it on who has antibodies out there. So I'm not, I guess the basic answer is I'm not sure. In terms of testing people, when we talk about enough testing, it's to test the right people and to be smart about it, not just randomly test everybody.
Okay, makes sense. Great. So moving off that, there's another question about what is the role of T-cell mediated immunity? Could that be more important than antibodies in controlling or clearing the virus in some people?
Yeah, I mean, certainly T-cell immunity is involved in protection, but we don't have a good way of measuring that. We measure antibodies. So, you know, I mean, we can measure the T-cell mediated immunity. It's just much more difficult. You're not going to do that on a large population.
Okay, good. Now, there's also some reports of people that were infected with the SARS-CoV-2 showing multiple negative tests clinically, but an X-ray, chest X-ray shows positivity. Have we considered using a chest X-ray, or would that be an effective addition to the screening?
Well, yes, it is. In China, they found that actually AI looking at, I don't remember if they were X-rays or CAT scans, I don't know, some diagnostic procedure like that was better than the testing. There's two, so the PCR does have false negatives. That's one problem. Also, the viral load may not be high enough to test positive in the PCR. You could certainly do that, but on a community-wide level, it's not very feasible. You know, in a hospital setting, you maybe could do it on a suspected case.
Great. Okay, so another person has asked, what are some lessons we can learn from other countries like Singapore or South Korea?
Yeah, so the countries, New Zealand's another example, that have successfully dampened the number of cases. First of all, have done widespread testing. And they put home, well, really quarantine procedures in place early on and kept them in place long enough. And these were very strict guidelines. You know, what was done in China, in Wuhan, and in South Korea just would not fly politically here. And so they were able to get a handle on the number of infections. They also shut down businesses pretty much. So they put very stringent measures into place. Now, I will say that some of these countries that did a good job, Iceland's another example, now that they're relaxing those guidelines, are seeing an increase in cases. Nothing has changed. The virus is still there. We still don't have a vaccine. And so, you know, it's only inevitable that we're going to see a rise in cases.
Another person has commented that it isn't likely that the New York virus is the same as the European virus, and that's different than the virus that we have here in Texas or on the West Coast.
It's certainly possible. The question is, you know, genetically, yes, they're different. The question is, does it make a difference in in transmission? Is one more infectious than others? There's no good data about that yet.
Another related question to the New York City is, let's see, it will probably be similar to, will New York City be similar to our experience here? There was a study done at Houston Methodist that shows Houston was seeded multiple times from the virus from Europe, China, and elsewhere.
Yeah, so I kind of doubt, again, my crystal ball not working so great today, but I kind of doubt we are going to see what happened in New York for a couple of reasons. New York is a very densely populated city, so people are in close contact. We are not. New York has a subway system that puts a lot of people in contact that a lot of people use that we don't. So we just don't have the opportunities for transmission as much as New York did.
Okay. And do you think that the virus in Europe and New York was more virulent than the one here, or is that even an issue to consider?
Well, it's always a possibility because, as I said, this virus does mutate. I didn't mention that unlike other RNA viruses, though, it has a proofreading mechanism. So it mutates less than other RNA viruses. So it's always a possibility, but there's no evidence yet that one strain is more virulent than the other.
Okay. Moving off about the virus, a question here about, do you have any idea when hospitals will start to allow visitors?
Oh, no, that's easy.
We should ask our audience here. Maybe they have a better idea.
Exactly.
Too early to tell, perhaps. Okay, so there's some early evidence of specific mutations increasing infectivity. A lot of conjecture at this point based on limited genetic sampling. It will become more clear over time. I am sure we will see other predominant viruses that infect better than others. Not sure if that's a question or a point of agreement.
Yeah, I mean, that's exactly right. We don't know yet, is one more infectious than the other. There's other explanations for what happened other than increased infectivity. But, you know, RNA viruses mutate, so.
Okay. Going back to some international focus, Brazil, Russia, India, Mexico are also showing high rates of new infections and deaths and have a significant population bases with low level of testing. Should we be concerned?
Yeah, as I mentioned, we live in a global society, and although right now we're not seeing a lot of travel go on, at some point, hopefully, you know, I mean, at some point we will. And so there's always the possibility of importation of cases. That's why herd immunity is so important.
I see. What can you tell us about the African countries and infection levels there?
So I just saw yesterday or the day before that all 54 African countries have reported cases. So it's widespread. Testing is optimal, and the healthcare system in most of these countries are not optimal either. So there's a big possibility there of a disaster. And then there are the economic consequences in these low resource countries. It's not good.
Okay, I have a lot of things going on in the chat, so let me be sure I didn't miss any. If there's any question that I didn't state, maybe resend it to me again. And I think I had a couple questions I think I asked. Antibody general testing. So you mentioned a little bit about transmission. This is a question I had. And I saw something more recently that seemed to be pretty well vetted about how easy or not easy it is to actually pick up the virus if you were at a sit-down restaurant, no mask, from someone at another table that is, 6+ feet away. The idea that it might get through the ventilation system and you would get dosed because of the duration that you're in the restaurant rather than, passing someone at 8 feet on the street that's not masked. Do you have any?
Yeah, there was a study out of China showing that transmission seemed to have occurred in a restaurant through the air conditioning system. It was one study. And again, those studies are going on, but there's just still a lot we don't know about the virus. One question I'm asked a lot is about hair salons and nail places, and is it safe to go get a haircut? Now, you can tell that I have not been to a hair salon, although it might be the first place I go when I feel safe. But my take on it is that, and it's the same with restaurants. So, if I fell and broke my arm, I would go to an emergency room. There is a possibility of spread there, but the risk is worth it to me. You know, the risk benefit ratio. Yeah, my hair looks awful, but you know, it's not, the risk isn't worth it to me. Same with restaurants. You know, I'll do takeout, but I just don't see a need to go sit in a restaurant and potentially be exposed. And it has to do, I mean, I am over 65, so I'm in a high risk group. I'm not taking care of anybody who, you know, also is in a vulnerable group, but you have to think about that as well when you're, you know, thinking about this risk benefit ratio.
Yeah, I see. Okay, so some new questions have come in. Thoughts about the BCG, the tuberculosis vaccine, and its effect on the COVID-19?
Yeah, interesting question. You know, there had been talk about that because countries that routinely do BCG vaccination, which we don't in the United States, seem to have lower levels of infection. Now, a number of caveats there. That's an ecological study. It's early in the infection. And again, I just saw a paper published, I can't remember where. I don't remember where. But anyway, where they looked in Israel, because Israel used to do BCG vaccination, now has stopped unless someone comes from a high TB country and is immigrating there. And they did not find any difference in infection rates or death rates between those who had had BCG vaccination and those who had not. The theory, and it's the same with the polio vaccine, is that it revs up your innate immunity, so it provides some non-specific protection. But
okay, I see. How likely is a vaccine, in your opinion, since this is an RNA virus?
I think I'm pretty sure we will get a vaccine. Now, there are some caveats that we don't know in humans which are the neutralizing antibodies and how long immunity lasts. So if immunity only lasts for a couple of months, a vaccine is not going to be very feasible. The fact that it's an RNA vaccine, I mean, RNA virus shouldn't make a difference. So is flu. I mean, that's not the issue. I think the bigger issue is how long it's going to take. And I think the initial estimates of 12 to 18 months was pretty optimistic. And I think it's also a mistake to think about the vaccine as a panacea, because as I said, 30% of people are already saying they're not going to take it. Even the president isn't sure whether he would get the vaccine or not. And then we have issues of, you know, who do you really want to protect? The seniors over 65 and those with underlying medical conditions. And the first vaccine we have probably won't have been tested in those groups. We won't know whether it's effective in those groups. So, you know, I think it's going to be a while before we have a good vaccine.
Interesting.
Just an allergy cure.
Good point. Okay, so the question about the hospital, I didn't understand it fully, so it's circled back, and I think the point there was that the government, you know, at large, gives multiple mixed messages about the safety of going out and where to go. But this idea that potentially when the hospitals open to start allowing visitors would be a better benchmark as to a truly safe environment, because obviously they would be more cautious. And so that was the point to be made about that.
Yeah. And you know, these stories that I hear about people not being able to visit their loved ones as they're dying are just heartbreaking, understandable, but heartbreaking.
So keeping with the hospitals, any predictions or thoughts that you might have or have read about on burnout or PTSD in our healthcare workforce after all of this?
Yeah, I mean, that's obviously a big concern. And I will say, same with our public health workforce. You can't keep working at this level, and particularly for our healthcare workers and first responders in this environment where you're worried about bringing the virus home because we don't have still enough PPE. It's going to be a big issue. And I think employers have to start thinking about that, about counseling for their workers. It's because hospitals are losing money at the same time. It's a weird thing, isn't it? You know, there are economic realities as well. And I think I read that some of the biggest job losses have been in the healthcare industry, which is bizarre.
Well, and that leads to the next question where someone points out that there's a lot of health impacts on society due to the stringent social distancing and shutdown policies. So people are losing their jobs, not getting health care, maybe that is even needed. Depression is up, suicide up, drug use up. So how do you factor these issues that are obviously, you know, very important into your decisions or even your modeling about how and when to open up, you know, businesses, if you will?
Yeah, I mean, that's a very good point. And that doesn't even talk about the children and what it's, you know, educationally, what's happening to them, the lack of socialization, just, you know, child abuse is up, domestic violence is up. It's really, really bad. And we get back to that triangle of, you know, between saving lives and the economy. But I think we do have to recognize that the only public health issue is not the virus. There are all these other aspects. You know, losing your home is not good for your health. And so I think what really needs to be done is we need to have multidisciplinary teams looking at this. I may know about the epidemiology, I can talk about that, but I can't talk about the mental health ramifications of this. The loneliness in our long-term care residents is horrible. I have an aunt, a 94-year-old aunt who's like acts like she's 60. I mean, but she just moved into assisted living and she's isolated. She's in a 1-bedroom apartment. She's getting no exercise. No, she can watch TV or read or listen to the radio. You know, she doesn't have a computer. She's not, it's horrible. And yet she's at very high risk of dying if she were to get infected.
Yeah, that's tough.
You need ethicists on that committee as well.
That's true. Absolutely. Absolutely. And I'm assuming those factors aren't necessarily being put into any of these mathematical models, which are just
the models are just looking at number of deaths.
Yeah. So question about the homemade masks, if in fact they're sufficient and how often they should be washed.
So masking is an interesting, here's something where I've changed my mind. When this first started, I adhered to the CDC guidance that masks, they don't protect like N95s, you know, and you have to wear them correctly. You can't touch the outside. You're supposed to change them every so often. I have read that homemade masks should be washed every time you use them. On the other hand, I just read a study showing that the virus only lasts a couple of hours on fabric. So, you know, maybe if you just rotate between yours. But we're now finding that these masks actually do prevent some infections. They're not perfect. The problem, and I mean this in a society sense, is that if I wear a mask, I'm not necessarily protecting myself from getting infected. I am protecting other people from getting infected should I be in the pre-symptomatic or asymptomatic phase of infection. And that requires community engagement and, you know, concern about others. Again, it's not this every person for themselves. And it's become a political issue. You know, there are stores that say you can't wear a mask in here. And that's too bad. So I'm doing an interview later today about when we should be wearing masks. And one of the questions was, well, if you're in your car, you know, no, I don't think you need to wear a mask if you're in your car with your household members or by yourself. But if you're out, you know, where you might come in contact with someone, yes. The other reason I was against masks, and this is still an issue, is that it makes people feel safe and they don't adhere to the physical distancing. Nobody said you just wear a mask. It's wear a mask and stay 6 feet away.
Good point. Good point.
And I think there was a question about what kind of mask. I mean, there are some fabrics that are better than others. I was looking on Etsy yesterday, and they have some linen masks. linen is not a good fabric. You can see through it, basically. You know, you want a tightly woven fabric. The problem is it makes it harder to breathe. You want double, triple layers. A filter in there is good. You know, there are some, and you want it to cover your nose and your chin, you know, the whole way.
Yeah, good. So another question real quick. Can you comment on Gilead's Resmetirom drug and how effective it may be?
Yeah, so this, you know, this remdesivir was touted as an antiviral for SARS-CoV-2, and in clinical trials, it reduced the number of days of symptoms from 14 to 11. It did not appear to have an effect on the number of deaths, although the sample size was small. Now, what was interesting about this study is that in the middle of the clinical trial, the endpoints were changed, which is not something you usually or should do in clinical trials. So, you know, I'm not saying remdesivir shouldn't be tried in severe cases, but it is not our, you know, miracle drug. And indeed, with viruses, I'm not sure if there are any cases where one antiviral works. Right now there are some trials going on of triple therapy. I mean, that's what we use for HIV. You know, viruses are tricky little beasts, and you know, one antiviral usually doesn't cut it. So I think we'll be seeing more multi-drug combinations used.
Good, interesting. Any other questions? There's lots of chat going on, but any other specific questions for our speaker this morning? That might be just going through. I'm learning to moderate WebEx. It's an interesting new skill set I'm going to have. I might be an expert. Great. I think that's about all of the questions that I'm seeing come in, and that's a wide range of interest that we have in our audience. So I want to say thank you. I really appreciate you taking your morning and sharing this, and I'm sure it's an evolving education for all of us, and you are definitely on the forefront of it. So we appreciate what your expertise and feedback here. Apologize, reading and talking at the same time is not my skill. A lot of thank yous in the chat. Thank yous, excellent presentation. Looks like one little last question. Should college students go back to the live classroom? And I don't know if you've heard officially from the UT leadership. I do know the medical school is expecting to do most things online or have very small groups in the fall, but I don't think our school has.
No, there was an email yesterday saying no, well, at least officially no decision has been made. You know, it's a really hard question, and I think it's even harder for college undergraduates, where that's really part of the experience, versus our graduate students. Now, I will say that I don't particularly enjoy teaching by WebEx, and it is not the same experience as being in the classroom for anybody, for me or the students. But, you know, I think I understand colleges have to make a decision now, but we really don't know what's going to be happening in the fall. There are a lot of possibilities.
Yeah, and just personally, I have 3 in college at 3 different universities in 3 different states, and there's mum's the word from all of those colleges. So I haven't heard anything. Louisiana, Colorado, and Texas, I haven't heard anything about those going back or not going back. So I think everything is still kind of up in the air. So
there are some that have made a decision, though. Like I know BU is online only. Didn't U of H? Rice is going to be in person. I think U of H said they were going to be in person.
Okay. Yeah, so it must be school specific. It's definitely not state decisions.
No.
Yeah, so interesting. Great. You're getting a lot of kudos in the chat. Excellent presentation, great conversation, etc. And a lot of things are coming about what people know about colleges. So hopefully folks can read that if they're interested. But thank you so much for your time. I really appreciate it. And a couple questions about the presentation. We recorded it and we will be posting it on the website. Stay tuned for an email from Mark, and that way individuals who couldn't join or non-members of the college can also benefit from Kathy's expertise.